Om Amriteshwari Namaha. Thank you, Dr. Bipin, for the invite. And it was basically Dr. Prem Nair who was supposed to present, and he, as a great leader, sublet this presentation to me. It was so good to hear Dr. Victor, and I think you're so fortunate to be working with mice, mouse, and wolf. Unfortunately, we are working with human beings, and things are extremely difficult. So I'll start with a lighter note before I begin this presentation. There was this husband and wife, and husband was not feeling well. So wife took this person to see a doctor. Doctor evaluated and said, you do few things and he'll be okay. Don't give him dirty looks for next 1 year and he'll be okay. Don't ask him to buy any jewelry or diamonds for next 1 year and he'll be okay. Don't discuss your mother-in-law for next 1 year and he'll be okay. Don't discuss your mother-in-law, daughter-in-law, sister-in-law serials which comes on TV every day with him and he'll be okay. So both of them were coming back home and husband asked, what did the doctor say? The wife said, you're not going to survive for long. And the scenario with antibiotic stewardship and antimicrobial resistance is similar. We earlier thought that it was labeled as infections, then it became nosocomial, then it became hospital acquired, and now it is called as healthcare associated, because all, you and me, are responsible, and we are not going to survive unless we really pull our socks and get the processes right. We could have said that for the institute, but we are not going to survive ourselves if our practices are not good enough. So we know that there are a lot of pumping in of antibiotics left, right, and center, at least in the developing countries, and it is pretty bad for us. But what we see as a, and this is true for Amrita, and this is true for most of the tertiary care setup within the country. In 2008, we were getting results something like this for Klebsiella, and it was earlier Pseudomonas, went to Acinetobacter, and now it's all Klebsiella. 2010, the reports are something like this, with sensitivity only to colistin. 2012, we are getting results like this, and it is just not 1 or 2 people. There are umpteen number of patients who get admitted with multiple comorbidities, and when you send tissue samples, you get a report like this where your hands are tied, you're absolutely at dead end to be able to do nothing. And this is the scenario throughout the country. And this is a dangerous scenario with respect to at least medical oncology and transplant program. And if you're not going to really get our processes right, we will have oncology programs and transplant program close in a couple of years, and maybe surgical programs close in another 15 years, and maybe hospital close in another 30 years, because it's so bad. So what did the government do? Government very hurriedly came up with a policy, because there was a publication which came up in Lancet that there is New Delhi meta-beta-lactams. And just because it was attached, the New Delhi word was attached, there was a very hurried policy which came, which was published, but it was a very idealistic policy and nobody could have implemented it, and that it was completely rejected. Now there is a draft which is coming up, and still the scenario is so grave that there might be resulting in closures, and there are lots of morbidities and mortalities. It is still in a draft form and there is no national policy up till now. So we at Amrita started our antibiotic journey for last couple of years, and we adopted a model, something called a start smart and then focus. So we have an antibiogram which exists for all tissues, for all departments, and according to that antibiogram, we start the antibiotics. It's very difficult to pre-authorize our clinician, because I don't know whether you have interacted with clinicians. Me being one, there is this clinical ego which is very, very difficult to survive. And there is a different hierarchy which exists in the hospital. There are cardiovascular thoracic surgeons, there are cardiologists, then there is God, then there are physicians and there are surgeons. So there are these group of people whom you cannot just touch or talk, and they just don't listen to you. So starting smart is you allow them to do it as per the antibiogram, and then we have an antibiotic stewardship committee which focuses, and we focuses on all these areas where we look at de-escalation, re-escalation, IV and oral switch. So we have 8:30 to 9:30 antibiotic stewardship committee which meets every day. We are looking at appropriateness of antibiotic. We are looking at 5 hours, right drug, right dose, right duration, frequency, and dosing on a daily basis. And then the ID physician internist along with the clinical pharmacist round with them. So we realized that the practice of loading dose was not being there for the antibiotic. The dosings were completely inappropriate. Those which were concentration-dependent antibiotics were given on a different dosing, and those were time-dependent antibiotics were given on a different time. If aminoglycoside was supposed to be given OD, it was given TDS and things like that. And the duration, somehow clinicians, we've realized, love few things. If you go on an OPD, your prescription will always be 5 days. And this 5 days, how this evidence comes, we actually don't know. And if you are admitted, it will always be 14 days. And how this 14 days come, we actually don't know. So this duration is completely on the whims and fancies of, of the doctor under whom you get admitted. So we have been working on this particular project almost on a daily basis. And there had been some very significant response. 78% of the colistin reduction we have achieved, and a linezolid of close to 84%. And all 13 high-end reserve antibiotic consumptions have reduced, that varies from 54 to 28%. And this has translated into tremendous cost. Just in particular, in 6 months, a pre and post is the cost benefit is close to 62 lakhs. And fortunately, this all cost goes back to the patient, because we have this out-of-pocket expenditure in our country. So whatever benefit you offer as cost-effective or benefit, it goes back to the patient. We also realize that our doctors, after doing their post-graduations, they don't undergo a continuing medical education with respect to antibiotic stewardship. So we have developed an e-learning patient safety module where they get into the Amrita Vidya, where there is an article which has been sent with multiple choice questions. First year, there was no doctor who appeared for this exam. It was completely because doctors are also averse to the word training, because they already feel that they know and they're trained enough. Next year, this has improved, and the third year, it has improved remarkably. So they choose and they work on this antibiotic stewardship as well as infection prevention. What also helps us is the hospital information system. Again, it is homegrown and indigenously built. There are sets of favorites for all doctors which you can easily put in. And once that is there, the drug-drug interactions, the allergies, the reminder dosing all happens, and it helps to reduce medication errors and any adverse drug events. What we also did, and this is again a unique project with respect to Amrita, is Sepsis Registry. And we developed our own registry program which doesn't exist in the country. And we looked at the surviving sepsis bundle at 3 hours and at 6 hours. And we are looking at all parameters at 6 hours. And we have close to 76% of the follow-up of all these patients who come with sepsis. So though there are lots of publications with respect to impregnated chlorhexidine catheters and impregnated alcohol catheters, we went back to basics and we only worked on training. Once we trained the doctors, including the nursing and the paramedical staff, we realized that it has tremendous impact on reduction of infection control. And in just one department in 1 year, the savings was close to 2 crores. So my investment was close to $1 for training, which was just 700 rupees per training. and my return of investment was close to $236. So I need not get stimulated with newer products and get stimulated with the newer introduction of devices. If I just get back to basics and train people properly, there are huge gains. We also worked on surgical antibiotic prophylaxis. We had a cardiovascular thoracic surgeon, and fortunately, he left our institute. So there were 434 CABGs which was done, and as a prophylaxis, there were 3 antibiotics which were used. And a good evidence is just using cefuroxime, single dose, or if the surgery is more than 3 doses. So he used 3 doses, and it was not appropriate, and the surgical site infections was something like this. There was a new surgeon who joined, who practiced evidence-based medicine, and he used cefuroxime. Surgical site infections reduced because the surgeon feels if you use most antibiotic, the infections are less, and we proved it is completely wrong, which also led to huge savings. And again, that adds on to the benefit to the patient. But we soon realized that if Amrita has a good policy and supposedly good practice, it's not going to help. Because if you are a tertiary setup, there are already a lot of patients who are being treated in peripheral centers and in secondary care institutions. They have been pumped in with lots and lots of antibiotic, and then they come to a referral center. And never ever you will have a scenario where it is practiced properly. So we approached government of Kerala, and we started working with them for the last 4 years. But they wanted some clue as it doesn't work. So antibiotic stewardship was not working. So we interviewed some of the practitioners in the state of Kerala, and we were very astonished with the results. 79% of them, they consider that it is a problem. 71% of them prescribe antibiotics on daily basis. So it is almost like a prasadam that antibiotic is given for every prescription or every patient who comes in. 65% of the physicians, they give antibiotic, they themselves believe that they give antibiotic more than it is necessary. 35% of them, they don't know the mechanism of action, but they are giving. 32 of them, they ask their senior colleague, how does it act, but they have already given the prescription. 52% of them, they prescribe because patients are demanding, give antibiotics, so they prescribe. Look at the practices and look at the low level of medicine being practiced at our state, which is so educated and which is so right conscious. We also interviewed microbiology because it works parallelly with them. 48% of them, the labs work with microbiology technicians. There are no microbiologists who can interpret the report. 72% of them, they give unjustified combination report. There are no discs which are available. 32 antibiotics which are banned, no discs available. You cannot test, but these reports are being given by the microbiology, and that is how more antibiotics are prescribed. We also interviewed pharmacists. 100% of them, there is a gazette publication from government that 2 prescriptions have to be given and 1 needs to be retained by the pharmacist. 100% non-compliance by all pharmacy stores in our state. 72% of them, they themselves are doctors and they are prescribing over the counter. Some patient comes and asks, I have loose motions, and then they prescribe. And then they also feel that they have become fantastic doctors. So it took us a lot of time, and when we gave this report back to the government, and then they realized that there is a problem, and then we started working with them. So we had multiple meetings at Ministry of Health and Family Welfare. We also got all 18 professional bodies like Associations of Physicians of India and Surgeons of India. There are 18 bodies. We then trained the trainers, and when we released a Kerala antibiotic policy. So there is no national antibiotic policy which is available, and we are very, very fortunate that Kerala is the first state which has a policy. And we thought that we have won the battle, but nothing happened. And we realized that nothing will happen until there are these 2 words called government order, which is issued by the government. So government then issued a government order to all hospitals, all labs, and all pharmacy centers to abide by this particular program, which is antibiotic stewardship. And we approached through a 5 steps process. One was approaching, there are 35 medical colleges, but until unless everybody is trained in practices, it is not going to work. We also worked on, there are 35,000 doctors, but until unless everybody is at that level of prescription, it's not going to work. There are at least 5 or 6 steps where if you have loose motions, you should not take antibiotics. If you have upper respiratory infection, you should not take. For skin soft tissue infection, you should not take antibiotics. So public needs to be engaged, and then should be a continuous research on prescription behavior. And unfortunately, I think that is where we are working with very, very difficult behavioral pattern and attitude, where changing that is challenging. And then we are also working on some key performing indicators to understand that there are good outcomes. It's not just we are doing antibiotic stewardship, but antibiotic stewardship has an impact. So we went to the Kerala government KUHAS, the university which governs 35 medical colleges, and we changed the curriculum. So undergraduate 4 hours, house surgeons 8 hours, and PGs 10 hours, because at that level, once they start learning what are good prescription practices, then the adherence would be better. And then we also worked on a lot of public engagement videos, though the government was supposed to build it, but Amrita has developed this, and it is there at WhatsApp and Facebooks and a lot of skits. Because we have worked with government, we are now working with a lot of universities. We recently have submitted a DBT grant on antimicrobial stewardship with the University of Melbourne. We are working with point prevalence surveillance study with the University of Antwerp. We are doing a systematic review with the University of Adelaide, Jonah Briggs Institute. We also have 8 people coming next week from University of Michigan. They are all ID specialists, and they are working with Amrita and working with the government of state. So there's a lot of movement which has happened because of some great impact which happened in antibiotic stewardship at Amrita, and because there is a lot of commitment from the government as well. So we submitted this, and we have got the Government of India Certificate of Appreciation for Best Infection Control Practices, and then recently we also got the award for BMJ. We realized this, and we got onto a technology. We have, last month we got the mobile app released, because we have 322 postgraduate students in our institute, and all of them, when they see a patient at ER, would prescribe which is rational. So they use this app, and according to the disease pattern, according to the patient pattern, and according to the antibiogram pattern, they can use this particular prescription. So coming to infection control, I'll just mention that we generally have a deeper belief that government does nothing, but there are huge programs from medical council, from dental, from nursing, from various bodies which we are working on infection prevention and control. But unfortunately, it's in a country which is so diverse, it is extremely uncoordinated and unorganized. A very, very simple thing of having a good hand hygiene practice, which are 6 steps before contacting and before seeing a patient we need to do. A doctor who comes to see his patient, and I'm talking about a pediatrician, and from my fraternity, he gets an alcohol hand rub, he washes his hands, he does like this, and then he goes and sees his patients. And there he contaminates, and it is how the infection keeps spreading. But what has happened is there is a national accreditation program which is there, and then they have developed lots of guidelines, and that has been practiced. In most of our Indian forums, we keep quoting US-based data, and I think that again is one change which needs to happen. And even in our country, there are these 383 hospitals which are accredited, and then there are plenty of healthcare-associated infection data which is available, and we benchmark our institution. And fortunately, Amrita is below the CDC and HSN and an Indian benchmarking. So there is a lot of data which is collected. I'll not get into that. Unfortunately, a lot of guidelines which are available, all of the CDC, IDSA, SHADE, WHO, all are pretty old. So they are from 2001 to 2009. In fact, world over, they need to really get on to better practices and get to a better design of guidelines, because that's going to help. We also got on to a Rockefeller Foundation grant with and worked with Institute of Healthcare Improvement, IHI US. There are 10 hospitals which work together, and we realized that every hospital has best practice. Whenever you take a patient, a neonate, there is a UVC light which is there, and if you use it, and this hospital demonstrated a decrease in neonatal infection. Just having a hand hygiene, it is not going to help. An elbow hand hygiene would be better. A decrease in bioburden with doing a wash of the preterms and the neonates is also have demonstrated. So when we collaborate with other hospitals, there are a lot of best practices sharing, and then we realize a very simple practice in PGI Chandigarh was that all the newspapers which they used to use, they used to autoclave it, and then they used to use that in the neonatal ICU as paper towels. So very simple, a good cost-effective way of using those. But if I have to take, as an infection preventionist, I will take my priority item only two, and that is hand hygiene and working on high-touch surfaces, and that's proven. And if we have adequate adherence to this, if we, in each healthcare institutions, and if you can also follow or profess the same two technologies, I think that would be a good war won. So there are lots of opportunities, there are designs, there are lots of bundle practices, but a lot of it is designed based on the publications which are there, and there is a lot of customization which is required, because somehow Indian settings in Indian organisms which are coming are very, very different. We don't see much of VRE, we don't see much of C. diff, we don't see much of MRSA, but we are seeing a lot of gram negatives, and it is very much Acinetobacter and Klebsiellas. So diagnoses have changed, so I'll skip this. So to sum up, what we basically want from a good antibiotic stewardship and a good infection prevention program is that just having a policy in a particular institution is not helping. So there needs to be a comprehensive coverage. There needs to be a national policy, and every state needs to have their own policy. Until unless that is done, it's not going to help. There is a lot of customization of bundle. There are lots of bundles, but those bundles are, and the practices are dependent on developed countries, and a lot of customization is required. And we have changed our bundles too, and we have seen that it helps. Training and behavioral changes are, I think, the two focus, because just training is not helping until unless the communication and behavioral change happens. The practices are not getting better. Every institution believes that they are the best, and we don't disagree, but until unless we start collaborating from the best of the institution, there are great learning which comes, and this is the one where we need to get going. There are other stakeholders which are involved, and which could be industry, which could be other universities. A lot of process and outcome indicators, we need to keep that database because I think we have been very, very poor in maintaining registries and databases. We also have unable to get into this work on cohorting and isolating and getting into standardization of practices. But if nothing works, at least we can start praying, and then we'll see that we will have a better infection control and practices. And if you land up in the hospital, at least you come back home safely without any healthcare associated infection. Thank you very much. Any questions? So if there are, yeah.
Yesterday I mentioned about an attempt we made in Delhi when Dr. Harshvardhan was a minister in Delhi. We formed a society for the promotion of rational use of drugs. It is not limited to antibiotics, it is limited to all drugs in a general way. And we got the assistance of PGI Chandigarh, All India Institute, and Sanjay Gandhi, because they're all relatively close to Delhi. A group of doctors also prepared a standard guidelines for therapeutics for various diseases, various indications. But none of this, from a practical point of view, worked for the same reasons that you mentioned. Because a clinician always feels he is the final decision maker as to what he should prescribe in the interest of the patient. And he is not bound by any recommendation by any committee. Now, the recent CDSCO announcement that they want to start a new schedule under the Drugs and Cosmetics Act, where antibiotics will come under a Schedule H1. That again is unlikely to succeed because retail pharmacists, the clinicians, and self-medication is going to continue regardless of what we do. So we need to have a practical outlook, and I'm so glad that you're making an attempt. But to what extent at the pan-India level it will work, I don't know.
Yeah, we are working with difficult Homo sapiens. Once that behavior is adopted, it's difficult, and they themselves deeply believe that they are sterile people. So that they secrete chlorhexidine from their hands, and they need not wash their hands. So just the simple hand hygiene, which Ignace Semmelweis said at 1841, and at 2017, we are working on the same 6 simple steps. It's unfortunate, but I think still some positive responses are there.
See, with hand washing, the problem is sometimes what you wash with the water is more contaminated than the hand. This happens. In most of the 40% of water in India is not only not potable, they are very heavily loaded with E. coli, Shigella, and whatnot. So that's another public health problem.
Correct.
Very, very interesting presentation. Do you, the multi-resistant and sometimes pan-resistant Acinetobacter and Klebsiella that you're seeing, do you believe they circulate in the community or only within healthcare facilities?
So CMC Vellore and ICMR did this study, and even in the sewage at Tamil Nadu near Vellore, they have grown multi-drug and pan-drug resistance. So it is just not within the institutes, it is there in each area. It must be there in the room, it must be there at each location. It is very, very serious. So it is there in the environment, but I may not get there. I think as a healthcare professional and as an infection preventionist, even hospitals where it need to be practiced well is not, we are not there. So I think environment and as a public health and a good hygiene is something which is much bigger project, which is beyond reach. But at least as an ethical and care which we need to provide in our healthcare itself, we know that the practices are abysmally poor. Right. Thank you very much.